of this presentation is define hemolytic anemia, define the term extravascular and intravascular hemolysis, various etiopathogenesis with clinical presentation of classified hemolytic anemia, laboratory investigation, and lastly, a basic introduction to autoimmune hemolytic anemia. So what is anemia? Anemia is defined as reduced hemoglobin concentration in blood below the lower limit of normal range for age and sex of the individual, and also in respect to the altitude the person is residing. According to blood parameters, it is clinical condition of reduced hematocrit and hemoglobin levels. How to suspect the patient is anemic or not? So the symptoms are tiredness, easy fatigability, lethargy, palpitation and tachycardia, paleness of skin, etc. And the signs are pallor in mucous membrane, conjunctiva, tachycardia, collapsing pulse, faintness, giddiness, menstrual disturbances like amenorrhea, menorrhagia, etc. Now, the classification of anemia according to the peripheral blood smear. There is three classification: microcytic hypochromic, normocytic normochromic, and macrocytic. So this is the blood picture of microcytic hypochromic, where we notice the central large pallor of the RBC cells. In macrocytic anemia, there is ovelocytes in the peripheral blood smear and also multilobated neutrophils. More than 5 lobes. Megaloblastic. Deficiency. So what is hemolytic anemia? The anemias resulting from an increase in the rate of red cell destruction with compensatory or decompensatory bone marrow erythroid hyperplasia, likely 6 to 8-fold increase in red cell production. On the basis of site of cell lysis, it is intravascular and extravascular hemolysis, and on the basis of cause of hemolysis, it is intracorpuscular and extracorpuscular. So how hemolytic anemia presents itself to the clinician? So presence of pallor of mucous membrane, positive family history in case of congenital hemolytic anemia, mild fluctuating jaundice due to unconjugated hyperbilirubinemia, splenomegaly, and in rare cases there is pigment gallstone due to overproduction of the bile salt. So there are three vital questions. Is there evidence of hemolysis? What is type of hemolytic anemia? And precise diagnosis. So the test for increased red cell breakdown, there is serum bilirubin, the unconjugated form is raised, urine urobilinogen is raised, serum haptoglobin is reduced due to binding with the iron, plasma LDH is raised, and evidences of intravascular hemolysis, hemoglobinemia, hemoglobinuria, hemosideриnuria, etc. So test of increased red cell production like reticulocytosis in PBS, various form, macrocytosis polychromasia, which indicates the immature form of the RBC. In bone marrow biopsy, raised iron stores noted in the Pearl stain, and in X-ray bones, expansion of marrow space, specifically tubular bones and skull. And the test for damage to the cells in PBS, various abnormal morphology cells like target cells, sickle cells, spherical cells, osmotic fragility is increased. In autohemolysis test, estimation of hemoglobin A and hemoglobin A by electrophoresis, and tests for sickling by sodium metabisulfite by consuming the oxygen. And the rare test is for red cell lifespan like 51 chromium leveling method. Now the classification of hemolytic anemia. In the acquired form, there is antibody mediated immune hemolytic anemia, under which there is autoimmune hemolytic anemia, drug-induced hemolytic anemia by the mechanical trauma like microangiopathic hemolytic anemia, by toxic effect by various infection, malaria, etc., and acquired red cell membrane abnormalities like paroxysmal nocturnal hemoglobinuria. According to hereditary causes, abnormalities of red cell membrane like hereditary spherocytosis, elliptocytosis, disorder of red cell interior like enzyme defects, D6PD deficiency, and disorder of hemoglobin. Now, autoimmune hemolytic anemia. This is the collection of disorders characterized by presence of pathologic autoantibodies that bind to the patient's own erythrocytes, leading to hemolysis. And when the rate of hemolysis exceeds the ability of the bone marrow to replace the destroyed red cells, to anemia and its attendant signs and symptoms. It is further classified into warm antibody and cold antibody AIHA. So the warm antibody AIHA, the pathogenesis are the warm type antibodies are IgG class, which coats the RBC, and by deposition of C3, it is lysed in the spleen. Now, the conditions predisposing to warm AIHA, like idiopathic causes, lymphomas like leukemias, non-Hodgkin's, Hodgkin's, collagen vascular disorder like SLE, drugs, methyl dopa, penicillin, splenomegaly, etc. Now, the laboratory findings: mild to moderate chronic anemia, reticulocytosis, prominent spherocytosis, positive direct Coombs test, unconjugated hyperbilirubinemia, etc. Now, the treatment. So, it is basically the corticosteroids are treatment of choice, where for 24 to 48 hours administration of corticosteroids, it gives response. Oral prednisolone at 2 mg per kg per day, or intravenous methylprednisolone 1 to 2 mg per kg used 6 to 8 hours may be used depending on the clinical condition. Now, cold antibody AIHA. It is further classified into cold agglutinin disease and paroxysmal cold hemoglobinuria. In cold agglutinin disease, antibodies are IgM type, and it is mostly reactive at 4 degrees centigrade, and there is agglutination of the red cells. But at the 37 degrees centigrade, there is reversal of this agglutination. In paroxysmal cold hemoglobinuria, the antibody is IgG type, which is directed against the P blood group antigen and brings about complement-mediated hemolysis. Conditions predisposing to cold AIHA. So, in cold agglutinin disease, the acute causes are mycoplasma infection, infectious mononucleosis. In chronic cases, lymphoma, idiopathic cause, and in PCH, there is mycoplasma infection, viral flu, etc. And clinical features are chronic anemia, which is worsened by exposure to cold, Raynaud's phenomenon due to vasoconstriction or vasoblockage, cyanosis affecting the cold exposed regions like tips of nose, ears, etc. And hemoglobinemia and hemoglobinuria occur on exposure to cold. In laboratory findings, there is chronic anemia, low reticulocyte count because the young red cells are affected more, spherocytosis less marked, positive direct Coombs test due to C3 deposition on the cell surface, but IgM is not located. And treatment. The treatment is basically supportive, covering the body with warm full sleeve cloths, using blood warmer like blood and intravenous fluids. And in cold agglutinin disease, the major antibody is IgM, which is the largest antibody, and it is basically stored in the intravascular compartment. So plasmapheresis is one of the options of the treatment. Now, little bit for other type of hemolytic anemia like thalassemia. It is basically a quantitative abnormality of polypeptide globin chain. There is two major types, alpha thalassemia and beta thalassemia. In alpha thalassemia, there is inability to synthesize adult hemoglobin, whereas in beta thalassemia, there is premature red cell destruction due to deposition of the alpha globin chains in the red cells as Hange bodies. Some most common mutations are transcription defect, translation defect, and mRNA splicing defect. Now, these are the charts where how many genes are deleted and where the hemoglobin level, how much is located, is noted. Now, clinical features of beta thalassemia. Anemia starts appearing within first 4 to 6 months of life, because after 6 months, the hemoglobin F is going down. Marked hepatosplenomegaly due to extravascular hemolysis, expansion of bones like malar prominence, like depressed of the nasal bridge, etc., and iron overload in some organs like endocrine organs, leading to delayed puberty, diabetes mellitus, and damage to liver and heart. Now, the laboratory findings. Anemia is usually severe. Blood film shows hypochromic cells, anisocoagulophytosis, basophilic cystic, target cell, etc. Serum bilirubin raised, reticulocytosis, MCV, MCH, MCHC significantly reduced. Platelet count usually normal but reduced in patients with massive splenomegaly. Osmotic fragility reveals increased resistance. And hemoglobin electrophoresis indicates there is increased amount of hemoglobin F, hemoglobin A2, and decreased amount or complete absence of hemoglobin A. Treatment. So the currently moderate transfusion therapy is indicated. There is 15 to 20 ml packed red cell per kg should be transfused regularly at 15 to 25 days interval to maintain pre-transfusion hemoglobin between 9.5 gram per dl and 10 gram per dl without any underlying other disorders or cause. Prevention and treatment of iron overload by desferrioxamine by IV route and oral chelation by deferriprone, and bone marrow transplantation is one of the method of treatment. Now, sickle cell anemia. The hemoglobin S is responsible for sickling in low oxygen tension. The major pathogenesis is due to substitution of glutamic acid by valine in 6th position of beta globin chain in hemoglobin S. So during oxygenation, there is distortion of rod-like polymers, hemoglobin S, and there is sickle shape of the RBC in oxygen crisis. And it is reversible sickling in the first time, but when the RBC membrane is lost by the spleen itself, it is irreversible. Now, clinical features. So this is severe chronic hemolytic anemia, primarily extravascular, recurrent vaso-occlusive episodes due to obstruction to the capillary blood flow by sickle red cells, impaired growth, and laboratory findings that moderate to severe anemia, blood film shows sickle cells, and features of splenic atrophy due to the splenic infarct. A positive sickling test by sodium metabisulfite, which consuming the oxygen from the surrounding environment, and hemoglobin electrophoresis indicates there is 22 to 20% hemoglobin S. So this is the peripheral blood smear of the sickle cell anemia. Now, hereditary spherocytosis. It is basically autosomal dominant inheritance, and most of the cases the defective protein is antirin, which binds protein 3 and protein spectrin as a bridge. And red cells are unstable due to this defect of the protein, and there is loss of membrane. So to acquire the same volume, the red cell become spheroidal, and it is called microspherocytes. But when it gets into the spleen, it is further lost the membrane, and now it becomes the macrospherocytes, and now it is lysed. So this is the peripheral blood smear of the hereditary spherocytosis, where the most of the cells are spheroidal in shape. Now the clinical features are anemia, splenomegaly, jaundice, and pigment gallstones, specifically due to overproduction of the bile acids. In laboratory findings, there is anemia, reticulocytosis, blood film shows erythrocyte in the form of microspherocytes, osmotic fragility is increased, and increased spontaneous autohemolysis, and the direct Coombs test is negative. It is distinguished this form from the aqueous spherocytes in autoimmune hemolytic anemia, where the Coombs tests are positive. Now, the last topic, the glucose 6-phosphate dehydrogenase deficiency. It is basically an X-linked disorder affecting mainly males, and females are carrier and asymptomatic. The G6-PD glucose 6-phosphate dehydrogenase is one of the most important enzyme in hexose monophosphate pathway or HMB pathway, where it is used to produce the reduced glutathione, which are used to reduce the oxygen, reducing oxygen stress of the RBC. Now, the clinical features are acute hemolytic anemia due to exposure of some drugs like primaquine, infection, thabamines, metabolic acidosis. There is chronic hemolytic anemia and neonatal jaundice. The infants born with G6PD deficiency may continue to have unconjugated hyperbilirubinemia and even develop kernicterus. The laboratory findings, basically it is a Heinz body anemia due to the deposition of the hemoglobin in the RBC, and there is destruction of the RBC by the spleen as is expressed as bite cells. Between the crisis, generally the patient is does not develop the anemia, and diagnosis of G6PD enzyme deficiency is made by one of the screening tests like methyloglobin reduction test, direct enzyme assay, etc. The treatment is basically stoppage of offending drug. The blood transfusion is rarely indicated. And this is the final chart of this topic of discussion, the approach to hemolytic anemia in short, which is taken from the Piyush Gupta book.